oftentimes little is known about this issue. So hopefully today will be an informative day. I am informal, which means that you're welcome to, I can't see for some reason like the chat or anything, but Mike is going to take care of that. So or you can unmute and just ask the question, because we are a small group, so I don't think that'll be an issue either. Okay, we're going to get started.
Tracy, let me jump in just for a second and introduce one person we have here at the RSVP offices with me. Isabel Hubbard's on the RSVP board and very involved in all kinds of volunteer and senior activities. So, Isabel?
Welcome, Isabel.
I'll talk loud. It's hard to talk through these silly maps. I will be so glad when we don't have to use them anymore. I'm a Madison retired teacher. I taught 30 years in the system, starting out in Kenosha and then moved to Madison. And after my little ones were in kindergarten, stayed in the Madison system. And at summertime, I would teach a couple of classes in the School of Education for those coming into the School of Education, in other words, juniors and seniors. And I became involved in RSVP, and this will be my 20th year. And when I was a teacher, I was so happy to have RSVP grandparents. We didn't call them grandparents at that time. We just called them as room helpers and coming to the various schools that I taught at. And I'm glad you're our topic person today. Thank you for coming, Tracy.
Thank you. I appreciate it. And thank you for sharing. And so I will introduce Noah, my cat. Noah attends absolutely every webinar I do. My students loved him, and he was nominated as a teaching assistant, though this is truly all he does. So there you go.
I forgot one person yet, Tracy, and you know Margie already.
Right. You
can't see her. She's over here working like crazy on stuff, like the Energizer Bunny, but Margie gets things going.
Hey, Margie. Copies of Tracy's presentation.
Thank you. All right, here we go. So what we're going to kind of talk about, I'm going to talk a little bit about the importance of the topic. I'm going to talk about the signs of substance use. And I want to say use. We don't use the term abuse anymore because it has the negative connotation that people are purposely misusing, and that is not always the abusing, and that's not always accurate. So I use substance use, and then elders at high risk. So what puts them at high risk? One of the most important pieces, I think, is the age-related changes, and this is where I think that more understanding is needed. And then I'll talk about the Beers list, screening, and treatment, and moving forward. And I did give y'all handouts too that we'll talk about. So in terms of the importance of the topic, most people know this, but I'd just like to mention, because sometimes people audience might not, but I think all of y'all know that boomers born between 1946 and 1964, you've got about 5 million have died now. So we have 73 million still alive, and they are still 10,000 every day turning 65, and that will continue until 2030. And we will reach the percentage where there will be more older adults than younger people. So anything to do with older adults is critical because of these large numbers that I know I started in gerontology. I got my master's in gerontology way back in the 80s. And we've been talking about this boom for forever, and nobody listened. And so now we're not as prepared as we should be as a nation. And then of course, COVID has brought out so much ageism. It's been named the boomer remover. It's die boomer die. There's a lot of ageism out there, and so that's been problematic too. So I wanted to give you some ideas. I'm going to give you just some numbers and things, but I always feel like we kind of need that foundation for how serious a problem is this. So one thing I want to say is boomers, you know, we were the drug generation. And I say we because I'm a boomer. I'll be 66 this year. And so we already know the rates as boomers are aging, the rates are higher than any other generation. And it's not just because of that. So many boomers did not continue with recreational drug use. But the other thing is narcotics. And we all know about the opioid crisis, and I'm going to talk about that more later. But there is greater access than there has been previously in our country to these prescription narcotics. And then the other thing to know about the 60 plus is it's, you know, yeah, when you were younger, it was about getting high, but now it's really more about, you know, addressing physical and psychosocial pain. And we are seeing a rise with COVID, with this social isolation, and how people are dealing with that psychological and social isolation that they are experiencing. And one way is substance use. So I just want to talk about two types of adults that we can encounter with substance use. So one is, people often say to me, well, that's just young people who now have aged in with substance use issues. But the reality is that's not true. We have two types. We do have people who have been using substances for years prior to 65. That is very true. But we also have late onset. And this is older adults who have reached 65, who prior to that did not have any substance use, didn't experience any issues with drugs or alcohol or whatever. But rather it's what's happening in their life after 65 that is resulting in a use that is not safe for them. So we really have the two groups. Issues for elders. So sometimes, with older adults, the issues, and I'm going to talk about physicians, and I always give this caveat at the beginning because I will be talking about physicians and lack of knowledge that physicians have around this topic. But I want to say that I'm not talking negative about physicians. In social work, we believe that you need to look at the societal context in which a person is working or living to see where issues arise. And what we know is that family physicians, etc., doctors, unless they specifically go into geriatrics, they're not being trained on how to prescribe for older adults. So to me, it's not the issue of the physician. It's the issue of a healthcare system, a society, med schools, etc., that are not training every physician should have knowledge of this, because every physician is going to work with elders at some point. Even people who work in peds, honestly, because grandparents are raising grandchildren. So I don't want anybody to feel like, oh, she has something against physicians, because some of my best friends are physicians. So the dose level, sometimes what is prescribed is not what is taken by an older adult. So they may be misusing a substance because of maybe they can't read the label, or they don't have a pill box or a way to kind of sort through their drugs. Longer duration than prescribed. Older adults oftentimes may take them longer than they should, and it may be that that is due to an older adult not understanding how long I'm to take them. If it's not made clear, that can be problematic. I often think about when my son was a little fella, he had a lot of earaches. And the very first one, I was a very young mother. So we kind of grew up together. And when I went to the doctor, he gave antibiotics and he said, these are for his ear infection. That's what he told me. And so when my son, didn't have pain anymore, I stopped the antibiotics. And of course, what happened was he immediately got the ear infection again, because you don't stop antibiotics, you give them until you've used them all up. But the doctor didn't tell me that. So it wasn't about me purposely ignoring the doctor or, trying to hurt my son, but rather I didn't have the information. And so that can be a problem for older adults, or not being able to hear well and not wanting to ask the questions. Using for purposes other than prescribed, maybe I'm depressed, and if I take my pain meds, I feel better, so I don't have pain, but I have the pain meds on hand. Using in conjunction, we're going to talk about this with other meds or alcohol, or skipping doses or hoarding drugs. So these are all issues that, whoops, went the wrong direction. These are all issues that older adults can experience. So I'd like to have 2019 up there as my data, but data for older adults often is very hard to get, particularly on topics that people don't focus on, and substance use among older adults has not been given a lot of attention. But this is the latest that we have, and it just shows you that there's not just people who are using alcohol, but also are misusing alcohol and medication, but also sometimes those are combined. We know that older adults consume the most prescribed and over-the-counter meds, which is problematic too, and we'll talk about. And you can see that the result of this is 14% admitted to ER, and it's of older adults, and it's due to drug and alcohol related issues. So of the people who admitted to ERs, 14%, it's because of those. And 20% of psychiatric hospital admissions. Those are high numbers of concern. 50% of nursing home residents have some form of alcohol use disorder. People are often shocked by that. They're like, but how do nursing home residents access liquor? Because oftentimes they're not, restricted to the facility, and they can go out. So they can go out and buy bottles. They can have bottles delivered. Some facilities allow for alcohol, and alcohol can be problematic because it has a different effect, and I'm going to talk about that. The effect can be much more quicker with a smaller amount than when you're younger. Widowers over the age of 75 have the highest rate of alcoholism in the U.S., the highest rate. And we know that part of that has to do with that social isolation. They've lost their partner, and maybe they haven't made those connections. And then older adults hospitalized as often for alcohol as for heart attacks. And I want to say right now that what is really interesting is, of all age groups, the age group that is most likely with treatment to recover is older adults. They recover slowly, but they have the highest recovery rates. And often the treatment is just when family members and friends show concern, what we know is that has to do with some of that isolation or lack of attention. So, people will say, well, there's no point, older adults can't change, which is another myth, because they can, and they can very much respond to treatment. So just some stats on prescription drug use, just that, we know that older adults are often overprescribed in terms of medications. And you can see here 89%, 54%, 4 or more, 20% of those taking meds report not doing so as prescribed, and it's due to cost. They oftentimes can't afford medications, which is another thing that physicians should be trained on. If there is not a social worker or a case manager, in a clinic, it's important not just to say, okay, fill out this, fill this prescription and give it to them, but rather talking to them about affordability. And then drug interaction, side effects, scheduling and taking. I mean, these are all issues in terms of that arise from things like having multiple doctors that are not in the same office, that are in different healthcare systems, people say, well, but there's electronic health records. But the problem we have right now is different healthcare systems use different electronic health record systems, and so they don't talk to each other. And that's one of the things that's being worked on, is how can we get these systems to talk to each other? So if I go to this doctor who maybe uses a different online system, it can speak. And so oftentimes, you know, there's no knowledge of one doctor by another that what they're prescribing, you know, is going to interact. The scheduling and the taking, there are some new things that have been, new technologies that have been developed, where you can have a pill box. We had the issue with my mom. She would mistakenly open the wrong tab or whatever and take the wrong amount, or think she took them and not remember. There are pill boxes now that will not open unless it's time for you, and they won't open again. You know, then there's the next, if you take them at noon, it will only open at noon. If you forget, it will sound an alarm. It also can be tied to a caregiver's phone, but those are expensive right now. And so they're often out of reach of people who would need them. Alcohol, oh, I just went back. Sometimes this goes forward. Oh, there we go. I think maybe I had the same slide. Opioids, yes, it is definitely a problem. And that's because older adults are prescribed at a higher rate than younger adults. And that has a lot to do with, you know, arthritis situations where we're experiencing pain. But it's also problematic because of what I'm going to talk about shortly, about how doctors are not prescribing appropriate doses, etc. And we know that that rate is rising, and that it's death related, use of emergency departments, hospitalizations, and so that is a huge issue. So that just kind of gives you like the basic foundation of the issue itself. And so I would just want to stop for a moment and see if anybody has any questions before I go on to the signs of substance use. Are we good, Mike? Nothing in the chat box?
Okay. Nothing in the chat box. I'm wondering a little bit on the background, you know, what percentage would you say, you know, for seniors at least, would be prescription versus non-prescription substances?
You know, I don't know that I have seen that, but you know what I can do is I will look and follow up, and then you can send an email out to everyone. Would that be okay?
Yeah, well, that's great. I'm just curious because, I mean, increasingly you see a lot of things offered at the health stores, and it would seem one can almost prescribe for oneself.
And a lot of that goes on with the internet, et cetera, and that is definitely a problem because it also can lead to, you know, overusing vitamins. There's a lot of things that the result is symptoms, dementia-like symptoms. So it is definitely a problem. But I will definitely, I'll look that up. I always tell my students I can't know everything, but I'm not going to make it up, but I can follow up.
Thanks, Tracy.
Okay. So the signs of substance use. And this is where it can be really hard, I think, to diagnose. Because part of it, if older adults are more isolated, so retired, less involved with systems, when we're going to work, people can smell alcohol on us, right? Or they might notice a change in our personality in terms of maybe I come across as high or my eyes. But for older adults, oftentimes they're retired, they're not as involved, or they may be more isolated. So there may be a lack of awareness that they do have issues. So that solitary or secretive use. The ritual of drinking before, with, and after dinner, sometimes that also, and people will say, well, but you know, I hear that a glass of wine is really good for an older adult. Well, a glass of wine maybe, but that's a glass of wine. And it depends upon the older adult. It depends upon what medications they're taking. It depends upon their weight, a lot of things. Loss of interest, drinking in spite of warning labels. Sometimes older adults can't see those warning labels. I have to say now that I myself am an older adult, I often have to go underneath a bright light, and sometimes I have to use a magnifying glass to read little print. So we don't have bottles that are made for older adults who need that larger print. And even reading glasses at some point do not help. So I always tell people, get a magnifying glass, but we shouldn't have to. And then immediate and frequent use of tranquilizers. Slurred speech, if you find bottles, the alcohol on the breath, or change in personal appearance, unsupported health complaints, hostility, depression, memory loss, confusion. So there's a problem with all of these signs. And if we were doing this in person, I would ask, the problem is that these signs also mirror signs of things like dementia, like memory loss, or other types of illnesses that an older adult can have. And so the problem with that is that if people are not aware that older adults, just like anyone else, can have substance use issues, then it's often it's not even detected, it's not assessed, etc. And so that can be a real problem. And oftentimes too, physicians are not trained about the fact that, I've talked to many physicians who say, well, yeah, I expect to see more depression in older adults. Why do we expect that? It is not a part of aging. Aging is a normal process. Becoming depressed is not a part of normal aging, or being hostile, or memory loss, or confusion. We have so many myths out there about what happens when someone gets older. But what happens is then we miss the real key things. So elders are at higher risk. Ageism. And the ageism, like I said, in terms of healthcare providers, the ageism, it's kind of like we're talking about racism right now, and people are saying, well, but I'm not racist. And what people are arguing is then you need to be, if you're not anti-racist, you're racist. Anti-racist means you're informed. Ageism is the same thing. If we want to be anti-ageist as healthcare providers, then we, like this morning, y'all are seeking out learning about this. You want to know. And so we need to make sure that people are educated on this, because ageism really, what happens is that ageism is, I don't need to check because the elders don't do alcohol and drugs. And if they do, I can certainly understand why I will when I get older, all of those kind of things. I've already talked about mimicking symptoms of other disorders. And there are times where it can be hard to distinguish changes due to aging. So like if a person has a balance issue, so when you're younger, people will often, that's even a test that's given, that you walk a line or seeing if you can balance, but your balance issue may be related to aging and a condition. So, it can be very difficult. But with training and with proper assessment, we can get past these. And I've already talked about being less likely in the workforce or trouble with the law, because being in trouble with the law, again, brings you into contact, any kind of contact with the system. It's more likely that we could detect issues, which makes it really much harder with older adults. And there's a lot in terms of older adults in crime and who gets arrested and things like that. A higher risk of med misuse because of elevated pain rates. We don't, and doctors, physicians will tell you, we still don't know how to handle every type of pain. And oftentimes the only way to handle pain is people just get sedated, particularly at end of life. And so when there are elevated pain rates, it can be then that drugs are misused. Sleep disorders, anxiety, cognitive decline, depression, all of these can put people at a higher risk of med misuse. the number of meds that you need to address different things. The fact that, like Mike said, that you can go over the counter, and we're going to talk about those drugs in a minute. So it really does put older adults at a higher risk. Okay, I'm going to stop, and I just want to make sure, and if y'all have questions along the way, you can put them in chat, but also feel free to unmute and if you have any questions before we go into age-related changes. People still hanging in there with me? All right. Noah's still sleeping. Okay. This is the information that I wish everybody knew, and that is the age-related changes. So I've kind of talked about things that up to this point, that those of you that are, so many of you are working at senior centers, RSVP, you know, you're already aware of maybe a lot of the information that I've given. This is the part that oftentimes people are less aware of. When I was doing my master's in gerontology, we had to take a geri pharmacy class, several classes, so that we would have an understanding of this. And so hopefully this will be helpful. So these are the 4 changes. Question?
Hang on, Tracy, just a second. Isabel has a question for you.
All right.
Tracy, in your comments talking to doctors, I found that so many times, even if I'm a Dean clinic person, I do my chart a lot, and you can contact your doctor that way. Or I have found if I've called the office directly early in the morning, you end up talking to a nurse or a nurse practitioner, and you don't have that conversation with your doctor because you're not seeing that doctor face to face. But I found sometimes what surprised me, I find out more information about what drug I am taking from the pharmacist than the doctor gives you the time to explain what may happen. And I'm wondering what your reaction to my comment is.
So that's a great question, and it actually is one of the more successful interventions. I partnered with United Way and a number of physicians, nurses, in creating a program that is still very active, and we partnered with pharmacies and with pharmacists, and the program is just that, and they have a sliding fee scale for that. You can go in and you can bring, so you, maybe as the adult child, the elder, if there's no cognitive issues, can take in the drugs, but you can take in all of your drugs, and they will assess your drugs, and they'll assess for interactions, and they will talk to you if they have a question about a particular drug, and they'll say, you really need to contact your doctor and talk to them about this and let him know that you're taking this drug, because like my chart is an EPIC system, but there are other systems used by other healthcare systems that EPIC doesn't talk to. So I definitely think a pharmacist, that's really good. It used to be easier, like I know when I was growing up, you had the mom and pop, I call them, pharmacies, and so you got to know your pharmacist really well. Now we have kind of the bigger Walgreens, etc. And so maybe don't know your pharmacist, but it doesn't matter. Pharmacists will, you can always call Walgreens or whatever and see if they are part of the United Way program, or contact 211 for United Way to see who's participating. Thank you for that question. That was a good one.
To me, they would tell you to call United Way. I can't imagine calling United Way to find out anything about my medication. That's a big surprise.
Yeah, you just, they will give you, if you call 211, you can ask them about their pharmacy program and just ask for a list of the pharmacies that are participating.
Well, that's okay. Okay, thank you.
Did you have a question about that?
No, it's just a surprise answer. Let's put it that way.
Yeah. They're, more and more, they're really looking at how can we have these programs for older adults that pharmacists, because pharmacists they're great. They're so knowledgeable and so helpful. So age-related changes. The first one I'm going to talk about is drug absorption. So as we change, so aging is a normal process, and there are things that are going to happen to our body that are just normal. They're just a part of aging. And I always say my body is like a car. When it was new, all the parts were like, woo, running great, full capacity. But I've been running this car for 66 years. And so my liver, it's a little older, my kidneys a little older, you know, all of them are a little older. And without any disease, they're gonna function a little differently. They're gonna be slower in what they do. And so if you kind of think about it like that, that is where we see the changes affecting drugs. So one of the things is absorption. So as we get older, we have less stomach acid, unless we have an issue with stomach acid, but usually we have less stomach acid. And intestinal blood flow, so the stomach acid works on breaking up the drugs that we put in, that we take in, that we ingest. And then the intestinal blood flow is about moving the drug through the system so it doesn't linger, and for our stomach emptying. So our stomach's going to empty, and then our intestines are going to be a part of moving the drug. But the problem is that all of those things, so we have decreased stomach acid, slower intestinal blood flow, our stomach empties slower. So what happens is that absorption, it delays any kind of action, first of all, and the drug can absorb and have a greater impact than it should. One of the examples I give is Valium. When, let me see, I just wanna, oh no, I know what it was. One of my examples is Haldol. When I was taking that Jerry Pharmacy course, I was young, a student, but I came in to visit. I was working in a nursing home too. And when I came in to see, I always saw this one resident who had no family. So I made sure I came early so I could visit with her. And when I came in one day, she was stiff. It was like, I spoke to her, I'll call her Mrs. Smith, and she just looked at me, and I picked up her hand to grab her hand. And when I did, her whole arm, everything just moved like it was frozen. And her legs were the same way. And one of the things they had talked about in the pharmacy course was that Haldol needs to be prescribed at lower dosages for older adults because of drug absorption. And so one of the side effects is this stiffening. And so I went and talked to the nurse and said, I know, I'm just a student, this could be wrong, but you know, this is what I'm seeing. She went down with me and saw Mrs. Smith, and then she looked at the chart and she said, yeah, her doctor has her on way too high of a dose of Haldol. She said, I'll contact the doctor and take care of it. And she did. And in about 2 weeks, Mrs. Smith was fine. So that's an example of if a doctor and a nurse, etc., the nurse was aware, she was trained, but if they're not, then and aren't aware of this drug absorption, that's problematic in terms of dosage. So we need to be careful about dosages because of this absorption. The other thing is distribution. So in terms of distribution, one of the things is that the amount of water in our body decreases and our body fat increases. Now, you're not gonna, people say, well, but I'm skinny. Well, that has nothing to do with the body fat on the inside of your body. Our bodies, as we age, develop this layer of body fat on the inside. And that body fat becomes dangerous in terms of what can accumulate in that body fat. So it doesn't matter what size you are, we all get that layer. So, and water, we talk about the need to drink lots of water, but because the amount of water in the body does decrease as we get older, But the reality is that not everybody does that. And sometimes people are constrained in having access to water if, let's say you're in a facility or you're living home alone. It may be hard to get up and get a bottle of water. You may not be able to do that as readily. I know in nursing homes in Switzerland and other places, they have created a robot where the robot is available, and the robot, you just press that you want water or whatever, and will bring you and will check in and make sure the robot can tell if you are dehydrated or not and brings that bottle of water. I don't think we're going to have that here for a while, but they are trying to think of ways of how we can ensure there's plenty of water. So if drugs dissolve in water, you don't want drugs hanging out in fat because the effect is going to be longer, and that's when you can get these toxic reactions. So the drugs absorbing that I talked about, but also the inability for the drugs to be distributed like they would in a younger person's body. So encouraging that older adults drink a lot of water is important, but it's also the importance of not having a dosage. It's kind of like with children, their organs are tiny, and so the drugs that the dosages we give children are smaller. Then as you become an adult, your organs get bigger, and so you can take on a higher dosage. But as we get older, they're still the same size. It's just that they have had a lot of wear and tear and they aren't functioning as much. So then we need to, again, look at a different dosage. So we wouldn't give kids the same amount that we would give an adult, and we don't need to be giving older adults the same amount that we would give an adult. But I'm not making a comparison. I'm not calling older adults children at all. Just yeah.
Tracy,
Okay.
we have another question here.
Cool.
From Isabel.
Tracy, when you talk about the water distribution, so many times on your medications, they'll say a full glass of water. In my mind, that's 8 ounces. What if you substitute, let's say, orange juice or a cranberry juice? Does that make any difference as to what would happen to your medication?
So what they say is that that water is the most important, and that's why, you know, oftentimes what you'll see is they will recommend water, because juices, they have acid, so that can have a different impact in terms of the drug. So taking it with a full glass of water is the best. Good question.
Thanks.
Anyone else? Okay. So drug distribution is really important. Drug metabolism is the other thing. So drugs need to metabolize, and they need to be able to break down, not only so that we get the effect, but also so that they don't linger in the body so we can get rid of them. So medications, they usually will travel to the liver or and some go to the kidney, and that's to be broken down and metabolized. And so I want you to think about the fact that your liver and your kidney, they're not functioning like they did when you were younger. And so that metabolism is going to be much slower, which again means that the drugs can build up. So what we want to do is, again, it's got to do with dosage. Dosage is key. Aging also can decrease that enzyme activity that happens in the liver. So there is an enzyme in the liver that is breaking down those drugs. And so that can be a problem as well, with the liver not breaking them down as much. And again, so you're getting this enhanced impact. So all of this is about why a higher dosage is going to give you a greater impact and going to impact you oftentimes at a toxic level compared to a younger person. So
Tracy, we have a question from Kelly real quick, if I can squeeze her in.
you bet. Kelly, go for it.
Hi, and you may be getting to this, Tracy, so I apologize if this is an interruption to your flow, but I've been wondering, as you've been talking about the different aspects of this, does diet and nutrition and consistent exercise exercise mitigate at all the way alcohol and drugs affect older adults?
So in terms of diet, what would really be the impact? Well, it depends upon if they have diabetes or whatever, because alcohol, the sugar. So some have more of an impact because of a particular condition that someone has. In terms of diet also, we know that the smaller we are in size, that the greater the impact of alcohol. And so that can certainly be problematic if an older adult is malnutritioned, or if they're just smaller in stature and weight. That's going to have a much greater impact than someone who isn't. And so that can be problematic as well. In terms of exercise, the issue with exercise would be, yes, you can burn off some of the alcohol if that is the issue. And it's true that our metabolism, things are improved when we do exercise. We know that exercise is really important, and so it can be helpful. But the problem oftentimes is that if you are already having a negative impact of the drug, if you're taking the drug, and then you go to exercise, you actually can end up falling and hurting yourself. Falls due to medication are a real problem, because not only is there this toxicity, but there's also the impact. If we think about some drugs that make us sleepy, think about the impact that would have on an older adult who's not metabolizing. So exercise can be important on the front end to keep our body, our metabolism going, keep our circulation. I often talk about that need for keeping our blood circulation. But it would only be more dangerous than if you're taking these meds and then trying to exercise. It's a really good question, though. And sometimes the size of someone is not always taken into account when giving drugs. So I'm smaller in stature, but what I took as an adult as a dosage, still I would need to have it down, because I'm still smaller in stature, so it's going to impact me, but I also have organs that are just older. So did that answer your question, Kelly?
Yes, it did. Thank you. With all that you're talking about with metabolism, absorption, distribution, I just wondered if all of that just does better with good diet and good consistent exercise. And I think I got the answer. So
yeah, it can kind of help, but
yeah,
it definitely can help, but it really, it's the dosage problem.
okay, thank you.
Mm-hmm. The other thing about the medication is that, oh, you know what? I want to go back for a minute. Let me go back. The other thing is the bloodstream. As we get older, the blood, the barrier, the blood-brain, we call it blood-brain barrier. So the barrier that is our brain, and that it actually, this barrier, what it does is as blood circulates and comes into the brain, it also, the barrier is thicker when we're younger, and it thins as we get older, and it's not as efficient at keeping out what shouldn't come in. So some drugs are able to cross over that barrier, and that can lead to problems in terms of memory, etc. So when people come, oftentimes students or different people will contact me and say, my mother has got some symptoms of dementia, she's kind of confused, etc. The first thing I always tell them to do is go take her to not to a family physician, take her to a memory care clinic, one that's what they specialize in. Because one of the first things they're going to do is they're going to be checking her meds. They'll also check for malnutrition, but they will definitely check the meds, because I remember at one point my mother had bleeding ulcers, and she had taken this medication all of her life. And then we started seeing confusion with her. And so I reached out to a pharmacist and said, she's taking this. Could any of her drugs have to do with what we're seeing in terms of the confusion? And because we knew the pharmacist in the neighborhood, and he said she shouldn't be on this drug for her ulcers anymore, because that is one that crosses the blood-brain barrier. She should change to another one, and that one doesn't. So even that awareness about which drugs that have the potential to do that is really important as well. So there's some drugs that older adults, and we're going to talk about this, and I actually have a list for you. And then the last change is the elimination. We know elimination is important, you know, that our kidney is able to, you know, slough out the drugs, etc. But the problem is that kidneys are slower, so you got less water for dissolving acid, stomach slower to empty, you've got the fat where it's increasing, you've got the liver where the enzyme is not breaking it down like it normally would, and then you've got the kidneys that are moving more slowly, they're less efficient. And so again, this is all about these increasing drug levels in our body. And so kidneys are also a concern. Again, drinking lots of water is a great thing, but it's not going to solve the issue. The issue is I feel like the issue is educating any healthcare providers, and I consider case managers healthcare providers, being on the front lines and having this awareness of the importance of drug checks by a pharmacist or doctor. So I'm going to stop there for a minute and see if there's any questions.
Yeah, I got a comment from, or a question, kind of a combination from Vicky. It says this can be addressed later on, wondering if later on in the presentation will be provided tools or resources to help address when AODA is affecting ADLs.
Yes.
And then it says, I have two specific situations, clients in which the family is struggling with alcohol consumption and how to deter or lessen. AODA is causing falls in the home and lack of ability to perform ADL independently.
Well, I just looked at my time and somehow it's almost 11. Let me look at something because I want to make sure I get to those. So this is what I'm going to do. Okay. Let me quickly introduce the beers list, and then I'm going to get to the treatment and address that. So I gave y'all the beers list, basically. It's the American Geriatrics article. The beers list has been around since 1991 when it was first created. The beers list is a way for family members can access it. Physicians should be aware of it. And what it does is every few years it's updated, and it talks about drugs that older adults should not take. And this is one way, this is one thing that we can do. So with the beers list, for example, it talks about benzodiazepines, and that these are used to treat anxiety, dementia, behavioral systems, etc. Valium, Xanax, Restoril, these are very dangerous drugs to older adults because they really do tend to impact memory, falls, etc. They increase urinary retention so that drugs aren't getting out of the system. So these are not drugs that older adults should be using, and yet these are the highest prescribed type of drugs for older adults. Another one is anticholinergics, and I said they're wrong, anticholinergics, sorry. And these are ones that are to treat other things that are very common issues for older adults. But look at the examples: Benadryl, Dramamine, Advil PM. So now we're getting over the counter. And these are ones that, again, confusion, delirium, falls, risk for fractures. So these are very dangerous. Older adults should not take them. And then these are just some others: Tylenol PM, Unisom, Alka-Seltzer plus allergy. So these are all drugs that over the counter or by prescription should not be taken by older adults, should not be prescribed. So because of the impact they have, the body can't handle them in an older adult. So all of that is important to be aware. Now, in terms of, I want to talk about, I'm going to skip for just a second to make sure I get this. What is really important in terms of working with older adults, because we do know that ADLs are impacted, and when the activities of daily living are impacted, it can mean that for an older adult, there goes their independence, and the danger too of falls, etc. So in working with older adults, what is highly recommended is that you do have a conversation with the older adult. Older adults, what some of the research shows is, and this is for any type of substance use, what the research shows is that it comes better from a professional than it does a family member. There can be defensiveness when it's a family member, particularly when it's adult children, feeling like I'm the parent. Don't be telling me what I need to do. You're the child, I'm the parent. So coming from a professional, when I used to practice, oftentimes I was the one who talked about the car, not driving anymore, etc. And older adults would take that better from me than they were their kids who had been talking to them about that. Being very supportive, non-confrontational. What you don't want to do is say you're drinking too much. You need to stop drinking. You need to only, anytime we're doing you need, you should, what we're going to get is that older adults are not going to respond. They're going to be defensive and they're not going to do anything different. So being supportive and saying, you know what, so there's some concerns in terms of you've been falling a lot. So let's talk about that. And I'm just going to ask you different questions about things that we know can lead to falls, and then saying, so, do you have glasses of wine, or do you drink some during the day? So you don't want to say, do you have an issue with drinking? But rather having that conversation. Because what you want to do is empower the elder. You want the elder to feel like, okay, we're having a discussion. It's not, I'm going to be yelled at by this professional or told what to do. So, and then being, like if they say, well, yeah, I did used to have just a glass at dinner. Now I'm having more. So tell me about, when did that start? And, tell me more about why. Because a lot of times what we're going to find is that there are psychosocial reasons for that drinking. So maybe they feel lonely. So then, what can adult children do, or what can we as professionals do to address that? And maybe we do need to work with the elder. Maybe they've had losses in terms of their support network that weren't obvious to other people. So how can we rebuild it? Or how can we build a support network to begin with? When we kind of use these techniques, they're more strength-based, they're more empowering, they're more of, let's you and I work together. And I often still work with adult children on, if they don't have a professional that they can reach out to, they feel like, on how they can do this same type of interaction. Because a lot of times that in and of itself will make a huge difference in terms of opening up the older adult to recognizing that there are issues, as well as always talking about independence. I understand that, you have more than one glass of wine, but let's address the issue that you said that you do that because you're lonely. So let's address that, because you know what, having more than one glass of wine, it really puts your independence at risk, because you could fall, or not be able to do this or that. We can also look at treatments There are very few facilities that really focus on older adults because this is not seen as an older adult issue. I did a 2-hour talk statewide for people working in substance use counselors, etc. And usually I've done this several times and had maybe 30 show up. I had a huge overflow. People were sitting on the floors. I had around 200, and they all said the same thing. Nobody's talking about this. You were the only person in the 2-day workshop that was talking about older adults. So that is really important. Is if we can bring this to more attention, we need more treatment centers that know how to work with older adults. Older adults are not going to go in when everybody is young. They don't feel comfortable. Thinking about that there are other considerations. It could be hearing. They're really isolated because they can't hear well. And they can't afford $5,000 hearing aids, and Medicare doesn't cover them. So now what am I going to do? Just being distracted, the eyesight, all of these kind of things can also result in this, substance use, because you can't see, you aren't communicating, you can't hear the doctor. I mean, there's a lot of things that can be problematic and result and need in terms of when we think of treatment. It's not always the treatment we think of for younger people. It's not just a facility. It can be that we really kind of need to sort through, are there hearing issues, all of these different things that I've been talking about. So the treatment is a little different. There are barriers to treatment in terms of language is a problem. We still don't do a great job in terms of having interpreters available. Insurance companies that don't cover treatment, lack of cultural competence, and I could do a whole workshop on that. Transportation, and literacy. Sometimes people can't read, so you can give them a medicine bottle, you can give them materials that say, but they can't read. And honestly, if you've ever looked at those sheets they give you with your meds that say I can't read those. So I want to just say that implications, just to wrap up to open for questions, because I did give y'all some screening instruments that are specifically validated, meaning they are been tested with older adults, the CAGE and the GMAST, and these are the ones that are used a lot. I'm on a group that is trying really hard to increase doctors automatically using like the CAGE, which you can use the CAGE aid for both alcohol and drugs. It's just short questions. Kind of like now when I go, they do a little quick fall assessment. Well, why don't we do an alcohol and quick drug assessment? So awareness campaigns, educating mental and physical health professionals, appropriate screening tools, interventions based on elders' living situations, integrated treatment models. There's so much that needs to be done that we aren't doing. And that as healthcare professionals, all of us right here, we can do. So I'll open it up for questions, and I apologize for going over. I usually have a clock in front of me, and I try to check my phone, but I didn't do as good a job.
Feel free to chime in, everyone. Great presentation, Tracy. Thank you so much.
You're welcome. Does anybody have questions? Hopefully I got the ADLs covered kind of quickly, but.
I have one question.
Yes, Ken.
You said that Haldol should not be taken by seniors. Okay. Now that's an antipsychotic, right?
Right.
Okay. So then I'm confused because you did talk about Haldol and before that somebody was they were given a higher dosage than perhaps they should have had, and I have a question about that too. What kind of a dosage would that be considered?
So dosages would not be my thing because I'm not a pharmacist. Okay. Yeah, I'm a social worker. But the thing about the article that I gave y'all, let me just a second real quick. The article that I gave y'all, the thing that I really is good about the article is it's not just the tables. It is that it also talks about in here, it'll talk about avoid. It gives you information on whether you should avoid it, moderate, etc. So there's a lot more information because what they're trying to do, and you coming up with a set dose would not necessarily work either because it would depend upon, for example, it would depend upon my weight. It would depend upon if I have any issues. So maybe I have a circulation issue. Well, that's going to make it much worse than someone who doesn't have a circulation issue. So there's also, and that's the thing with doctors, they can take these things into consideration if you train them to do that. So the thing that I also say is be very careful on the internet. The internet has a lot of junk and a lot of bad advice. There are sites that are really good, like the Mayo Clinic. There are sites that are good that you can read up on, but also just being careful. And you can always contact a pharmacist.
Okay, thank you.
And also, the other thing is, I'm just going to throw this out there, Risperdal, some of these benzodiazepines that we are giving, the antipsychotics that we're giving for dementia, for people diagnosed with Alzheimer's, that's the thing that's really dangerous. We are giving them at high dosages. I walked into a nursing home one day and I saw an elder just fall flat and hit his forehead on the tile floor, and he was overdosed with Risperdal. I teach dementia trainings on how to work with people who are diagnosed with different types of dementia. There's a lot of behavioral things that we can do. We don't always need to drug people up. So sometimes we don't even need to be giving the drugs that we're given. It has to do with facilities being understaffed, undertrained, and so drugs become the treatment of choice. Other questions? And y'all, on my slides, the last slide has my email address. If I was unclear about something, or if you feel like, she didn't address that or whatever, you're welcome to email me. I respond quickly to my emails. My students have trained me well. And so I always respond within 24 hours, if not sooner. And so I'm happy to answer additional questions. It's always hard to do something like this in an hour, and I tend to get over enthusiastic, as everyone tells me.
And I can't